as Eileen said, I'm a GP in North Somerset. I didn't know I was living in a Lyme disease hotspot until it quite literally bit me on the back in 2018. And I, as a GP, as a doctor, as a patient, as a doctor-patient, I have this unique sort of view into both sides of this very complex illness. And I wanted to tell you my story and my experience from sort of both sides. Predominantly as a patient, I guess, but as a doctor also. And as I've become more aware of it, as it is on my radar, I'm seeing a lot more of it, and people are sending more patients to me. So I'm just going to share my screen now. Is that? Can everybody see my slides? That's great. So,
fine, Rachel, we can see it.
Lovely, thank you. So, as I mentioned, I'm a GP, and I'd certainly heard about Lyme disease, but I didn't think for a minute that I would be unfortunate enough to contract it myself and to present, not only that, but to present with disseminated symptoms. So my credentials here mean that if anyone should have known about Lyme disease, it really should have been me. So I work as a clinical assistant in dermatology. Years ago, mine did do a degree in microbiology, Cub Scout leader, and live quite literally on the edge of woods in Clevedon. We have deer. I thought I did know about Lyme disease, and I'd seen maybe a couple of cases over 10 or 15 years, but I didn't realise quite how common it was. And so why raise awareness about Lyme disease? We as GPs are so critical, as well as our frontline clinicians, our nurse practitioners, our pharmacists, as Arlene says, absolutely critical to preventing sort of the morbidity associated with late disease. We have such potential to make such a difference. And diagnosis can be challenging. We're missing this. We're missing this even when it's fairly obvious, because it isn't on our radar. And this is why we want sort of just to raise it, raise the profile amongst the public and patients and doctors. Lyme disease does need to be on the radar of every frontline clinician. And my experience as a patient has been rather harrowing, but my illness and my experience doesn't even scratch the surface of the experience of many Lyme disease patients that I have come to and sort of met personally and read about. And so I just feel this responsibility really to share that story. So this is a lovely picture that just sort of illustrates how easy it is to miss ticks. So this is somebody's back pocket. It's a magnified photo you'll see of a back pocket. And these are nymph ticks. They are tiny, the size of a poppy seed. And these are the stage most likely to transmit Lyme disease, because they will have already had one blood meal as a larva. So when the egg hatches, the larva will feed on a mouse or a bird, and then it will drop off and molt to the next stage. And these potentially carry Borrelia and are more likely to transmit. And you can see how easy it would be not to notice, especially if you're wearing dark clothes. You wouldn't notice that. It would crawl upwards. It might burrow itself into your hairline, or it might burrow into the groin or your tummy button, and you may not notice that. So this is my friend's leg, and she happened to be bitten on the very same day that I was, and you'll see how different our stories were. This 22nd of June 2018, and she just got this sort of illness about a week after that bite, and she just had some stiffness in her neck and just felt very, very tired. And that sort of symptom started on the 30th of June, so about 8 days later. And then 2 days or so after that, she noticed this rash on her thigh. And she noticed that there had been a tick on her thigh, and it had been there probably for about 15 hours, she worked out. But she noticed this, and she was getting more and more unwell, photophobic, couldn't go out in her back garden. It was summer, it was quite sunny at the time, it was a lovely summer. And she went to the doctor. She's feeling really unwell, and she showed them the rash. And the clinician that she saw said, "Oh, it's probably nothing. Just watch and wait." So she was turned away. And it was actually her son who had done work experience on the Mendips with some environmental agency that said, "Mum, you've got Lyme disease." And these were probably a couple of days apart. So this was quite a vigorous rash. She was really quite poorly. And then she went back and she did get the treatment that she needed. And she did get better, hopefully. This is my mother-in-law. Just recently, just the September just gone, and doesn't remember a tick bite, but she had been in our garden. I'm going on about Lyme disease all the time, telling them every time they come over, you've got to do a tick check. She hadn't noticed a tick at all. And anyway, she didn't tell me about this rash on her leg. It probably happened a couple of weeks after she'd been in our garden, and her GP had thought about Lyme disease. And apparently she said, "Oh no, I haven't had a tick. I don't think it's that." So this is where we can be led by our patients or misled by our patients. And anyway, the GP gave her some flucloxacillin, but she wasn't unwell at all. She wasn't, and certainly with the cellulitis, I would expect somebody with a rash like that to be a bit poorly with a cellulitis. Anyway, didn't work, clearly. A week later, she's got this spreading edge. And a central clearing, at which point she said, "Oh, would you have a little look at my leg?" And I said to her, "Look, you need to get treatment for Lyme disease." And she did, and thankfully she was fine after her 3 weeks of doxycycline. This is somebody else I know. This is a 12-year-old boy, son of a friend of mine who's a very senior nurse. Now, she noticed that he had a mark on his neck. He had been a little bit poorly. She took a photo of it. So 22nd of May, he developed a flu-like illness. Nothing obvious initially. She is a nurse, a pediatric nurse. She was like, "Oh, you're fine, you'll be fine." Left him at home when she went off to work with his big brother, and noticed this odd mark, sort of took a photo of it. And over the next 2 weeks, he got progressively unwell with joint pains, appetite loss, 2 kilograms of weight loss, and in total 5 kgs over the whole illness, headache, developing neck ache, stiffness, and then meningism, at which point she knew very much what was going on. She took him to see her consultant colleague, and he got immediately seen, immediately treated. They did take serology, it was positive, and he had an excellent response to amoxicillin. Within 3 to 5 days, he was much better and didn't need any more treatment, and he has been fine. And this is sort of one extreme, really, I think, of the spectrum of Lyme disease. So he was very ill. He had a good immune response, positive serology, and was promptly treated and had a good complete recovery. And there are patients like that, and those are the reassuring ones. Okay, so this was something that came up in one of the Lyme disease forums. This is something that could easily catch us out, and just illustrates really how we need to just revisit things and listen to our patients. This 4-year-old boy had a little insect bite behind his knee. I think it probably was quite itchy. He was scratching it. And these photos sort of were over a few days. It was sort of getting a little bit more infected looking. And he was becoming a bit unwell with this, just non-specifically unwell. Mum was worried. And I don't recall whether she knew that there was a tick or not, but she certainly had it on her radar. She knew that tick bite was a possibility. And she kept taking photos, and here it was. So the child was treated with a flucloxacillin for the infected looking bite, which was completely reasonable, but this then occurred. And Mum said she actually went to 6 GPs before one acknowledged that this was Lyme disease and gave her the treatment for Lyme disease. And it was very difficult for her. She knew what this was, and I think each doctor had sort of looked at what the previous doctors had said, and it took a while for them to clock what was going on. And this is why I think it does need to be on our radar, because it can catch us out, and you can get infected bites as well as an erythema migrans, and that dual diagnosis is a bit concerning. So these are rarer, very rare manifestations of Lyme disease. This is a lymphocytoma, and in children it often occurs on the earlobe, just a little nodule really. Pinky purple, can occur on the nipple as well. That's another common place, but any funny lesion like that, Lyme is really worth considering. And this is acrodermatitis, chronica, atrophicans, which is associated specifically with the Ascellii strain, and it presents really late, but it can be very painful, and it's quite rare, but evidence of definite Lyme disease. So erythema migrans, migrating redness, as Anne said, it can occur anytime from 3 days to 3 months. It can occur months afterwards. Very variable appearance and behaviour. It's not always a bullseye by any stretch of the imagination, and what it is actually the immune reaction to the migrating spirochete. So you don't get the epidermal changes that you would get in ringworm, for example, or in shingles. And it's really in the history and observing it, because it does actually get bigger and bigger, because that spirochete's migrating out through the skin, and it can catch us out, cellulitis, ringworm, and in the very early stages, you can get a tick bite reaction. Some people do get quite a reaction to the tick bite, but that will resolve after a couple of days usually, and the EM will continue. And so worth getting people to take photos and watch it. And the main takeaway points about treatment are sort of it's effective and curative if you give a decent dose promptly, really important. And because of the dire consequences of not treating early, sort of my rationale now really is just, if you're in doubt, just treat. The disease can disseminate early, and certainly in my area, where within 4 weeks or so, 6 weeks maybe of my Lyme disease diagnosis, 4 of my close contacts, my book group, also had Lyme disease. And in that Woodland Edge area where it's so rife, I would think that there would be personally a justification for prophylaxis, but you can't extrapolate that, and it has to be on a case-by-case basis. As Anne mentioned, the Jarisch-Herxheimer reaction is one to be aware of, and it could trick you into stopping antibiotics if you're not careful, because the treatment can make you worse. As we've known, paediatric doses are unusually high, and Lyme isn't the only nasty thing carried by ticks. So to be aware of that, but that's really more the realm of infectious disease consultants, obviously, but we need to be aware and possibly ask for a tick panel if we think this isn't quite fitting. So this is a lovely infographic. I like this and I use this a lot, and it's just nice to have a quick reference. It's the BMJ, it's on the Lyme Disease Toolkit, you can download it from the BMJ, and yeah, very helpful, nice and colourful as well, just to have on your wall. So I've got a couple of cases, and these are patients I've seen as a GP, and they illustrate some of the points really that we some of the pitfalls. So this 12-year-old girl, insect bite on her leg after playing in the woods locally, and she had a little bit of discomfort and she started to get a bit of a rash, and 2 days later in this case she then got the fever and the headache and a bit of tummy ache. And remarkably, she was seen in our emergency department, where we do have a very experienced EMP who's really on the ball with diagnosing Lyme disease and has done a lot of awareness with there. She was diagnosed with Erythema migrans. So she got the diagnosis. It was brilliant. And she was prescribed amoxicillin for 21 days. No dose on the discharge summary. And then she was advised, quite rightly, to see the GP in 3 weeks if she wasn't better. So it's all looking quite good, really. Early diagnosis, right length of time of treatment. Choice possibly is a little bit of a concern. But anyway, 3 weeks later, she came to see me. And she was still poorly, and she was only just managing school. She was in bed a lot of the time, sleeping a lot, not eating, really hot and sweaty in the evenings. And there was no sort of, and so at that point, I thought, gosh, what do we do? And what do you need to know? And what should we do next? So there was no dose on the discharge summary. And so that was the first thing, is that I asked Mum, what has she been given? And the dose was 5 mils 3 times a day of amoxicillin, which is 250 milligrams. Now this child was 31 kilos. We know that she should have been having much closer to 1 gram. So she was pretty much on a quarter of the dose. And I examined her. There was no alternative explanation for her symptoms. This was Lyme disease that had not been treated with an adequate dose. And so we actually started doxycycline at an appropriate dose for the weight. And I did a pediatric referral as per the guidance. And she was worse a week later. And sort of I was getting quite worried about her at this point. But again, sleeping all the time, really all over the place emotionally, unable to go to school and not eating. And at that point, I could have, lost my nerve, but it was, I think, a case of the Jared-Herxheimer reaction. I did speak to a paediatric consultant who's experienced in Lyme disease and said, look, I want to give her amoxicillin as well. So I ended up treating her with doxycycline and amoxicillin at full dose for the 4 weeks. And thankfully she was okay, but I didn't want to delay it anymore given the delay that she'd already had. So a second case was a walking holiday, 35-year-old, very successful, very active person, walking holiday in the Scottish Highlands 6 weeks ago. She had noticed a tick bite on the forearm, promptly removed with a tick twister, and no rash, but gradually increasing in fatigue, sleeping all the time, unable to exercise. As a very, very fit and active person previously, she had headaches, photophobia, and the phonophobia that Anne mentioned, this hyperacusis, she couldn't stand noises, neck pains, which is a bit of a theme, and these muscle aches. So my GP colleague was brilliant and did some serology and commenced doxycycline appropriate dose, but there was little improvement, and she still had ongoing fatigue. She couldn't even drive, could barely walk a mile, having previously run 5 miles, and she was getting aches, pains. All these symptoms were just not really responding. And so at that point, as per the NICE guidelines, we started her on the amoxicillin, and 11 days after, she still wasn't that much better, but we decided we'd carry on for the full dose, and she made some improvements, but was really struggling to sit up at a desk. She was struggling to think. This was really catastrophic for this person, and marginal response she had. So, but still very, very debilitated. And her Lyme serology was negative at that, both at the 6 weeks after the tick bite, and then again, we did it again, it was still negative at 10 weeks. And that's the end of the recommended treatment under the NICE guidance. That's the end. You've had your treatment. And of course, we discussed we're going to refer you to infectious diseases. She actually had done a bit of research. She asked for a referral to a private specialist, and this private specialist saw her very promptly and gave her a further month of triple antibiotic treatment. And actually, she had a dramatic improvement by the completion end of this regime. I think many patients, when they go privately, do have longer treatments, but this case, month of triple, and she was much better at the end of that. So I think that there are some questions that raises, and what would have happened to this lady if she'd not remembered a tick bite? Luckily, we knew that there was a link with a tick bite, and what if we believe that negative test? If she hadn't, she might have remembered the tick bite, but she had a negative test. Now, in my experience, a lot of doctors would say, "Oh, your test's negative. That's all right. It's not Lyme disease." And if she'd had to wait several weeks, as she might have had to see an NHS specialist, what would have happened? And what if that specialist had adhered rigidly to guidance and said, "That's it, you've had your treatment, this is post-treatment." She did get better when she had more. So my story, I'm going to tell you about, and it's interesting that it's really quite different to some of these other sort of different and similar. And this is my tick, and it's a bit warped because it was in my freezer for some time. So I'm just going to go back. So my tick, I had that when I was I got bitten on the 22nd of June, same day as my friend who had the lovely rash. And it was an insect day. We were taking our children to Alton Towers. And I remember waiting on the grass veg for my husband to turn the car around. And I think that was probably where I got it, at the bottom of the driveway. And I pulled off a tick that night. It just lodged just under my bra strap, because ticks do tend to go up and then stop somewhere nice and where they meet a barrier, which is why they go into creases. And I'm only 5'3" inches, so I'm sort of more child type really, and so above the waist is quite common in smaller people. Anyway, I knew I had a tick, put it in the freezer, didn't think for a minute I'd get Lyme disease, thought, oh, it's really rare. I got the tick off, within about 15, 16 hours with a tick twister, did it properly. I thought, oh, I'll just get my husband to check for, my back, just check my back for EM rash, I'll be all right. If I've got Lyme disease, I'll get a rash and then I'll be fine. Anyway, I was absolutely fine for several weeks. Husband checked probably for about 3 weeks, after which we both got bored checking and nothing had happened. Thought I was absolutely fine. Until one August afternoon, 7 or 8 weeks after that original bite, I started to get twitches around my mouth, quite marked twitches, also of my calves, my hands and my lips. So it was the thenar and the hypothenar eminences just twitching. You could see the muscle fasciculations very visibly. I could see my lips quivering. And I remember being in my GP clinic, really worried that the patients could see my lip moving and biting my lip. And I started to get insomnia around that time. And then over about 2 or 3 days, had some tongue numbness and some right-sided facial numbness, and it felt like I was getting a Bell's palsy. That's what it felt like. And I remember waking up, I was worried about what this was, and I remember waking up in the night, having that light bulb moment where I connected the tick bite with my symptoms. And so I spoke with my GP and I explained I thought I had neurological Lyme disease. By then, clearly it was a disseminated infection. And these twitches were becoming rapidly progressive. I was actually away with family in Kent at the time, so my GP was brilliant. She sent through the antibiotics, and I started them. I got my daughter to take a photo of my back. I thought, is there anything there? And sure enough, when you look closely, there was a rash. So you can see just about that there was a punctum in the middle. You could still see the tick bite, and you can see this sort of line here, a sort of almost triangular, and I think you can see it going up sort of here, but it's just not obvious. It did get more obvious after a shower, but it was you know, you could have missed it really. And certainly if I wasn't actively looking for it, I don't think anybody would have really spotted it. And interestingly, when I did have a shower, I was getting blotchy erythematous rash over my back and my shoulders. So I had a disseminated EM rash all over my trunk, but only really visible after a shower. And so I started doxycycline for 4 weeks. Symptoms definitely responded. Within about, I'd say 36 hours, I had a fever. I hadn't been ill at all. I had these twitches, but I hadn't felt ill. And at 36 hours after starting the antibiotics, I was in bed, felt ill, fever, off food. And that lasted for 5 days, and that would have been the Erythema reaction. And after 4 weeks of the antibiotics, I stopped them quite happily. Still had a few little symptoms, which I could live with, but I relapsed quite significantly within just days. And I didn't just relapse back to my baseline. I was getting new symptoms. They were developing, they were spreading. It felt like a very active process to me. I was getting chest pain. I couldn't lie on my left side. I was getting palpitations. I was getting new twitches and new sort of symptoms in areas that I hadn't had before. So I spoke to a colleague on call in infectious diseases. They said, oh, just take some more doxycycline. So that's what they did. And, you know, helped a bit, so that was brilliant. But it was at that point that I noticed that I'd actually lost a lot of weight. I'd lost quite a lot of hair, and there was clearly something going on. So I asked for a referral to the infectious diseases, and I knew I had disseminated disease, and I knew that, having read that there was this huge lack of evidence over the best treatment for the later stages of Lyme, and that did make me a bit concerned.
So I had an appointment with the infectious diseases department, and by that time I'd had about 7 or 8 weeks of doxycycline. I was just coming to the end, and I was much better again. I did have ongoing, very visible fasciculations in my hands. They were a bit irritating and very visible at intervals, perhaps occurring a couple of times an hour. But they weren't bothering me too much, and they weren't interfering with function at all. I had a clinical diagnosis. One of the nice quality standards is that we should diagnose Lyme disease based on the EM rash. And I was lucky. The NICE guidance had just been published, and I am medically trained. I had my diagnosis. Strictly speaking, I didn't need a test. EM is pathognomonic of Lyme disease. But I did have tests at both 8 weeks post-tick bite when I first presented to my GP, and then again at 14 weeks when I had had the antibiotics and was seen by the ID consultant. Both tests were negative. This opened a real can of worms for me, both as a patient and a doctor. So NICE guidance suggests it can take up to 6 weeks for a response. But my tests were negative way beyond that, and I had disseminated symptoms, both a disseminated EM rash and peripheral neurological symptoms, not to mention the chest pain and palpitations, the weight loss, hair loss, fatigue that I'd had. It wasn't an insignificant illness, and yet I was still negative. So it seemed I was a real false negative case. The consultant was reassuring and felt that although my symptoms were rather odd, no further treatment was needed, and that this was really residual post-Lyme symptoms, possibly even something else, but that I'd had more than enough antibiotics. So I had a lot of questions, but in that busy NHS department, it was impossible to have the discussion that I wanted to about this two-sided can of worms that is seronegative Lyme disease and persistent symptoms after antibiotic treatment. My seronegativity really bothered me. If I had not remembered a tick bite and had not been a doctor, I know that I would not have had a diagnosis until much later, if at all. Probably would have got much sicker. I'll just never know. But I know that there must be other patients like me, possibly struggling to get a diagnosis and therefore treatment, because it is so difficult to make. So why was I seronegative? I knew my response had been weak and slow. My EM rash was rather pathetic when you compare it to the others. So my friend who'd had a very clear bullseye rash on her leg with fever and headache, very vigorous response there, but I had not been unwell at all. And I began to ask questions. Is the negative test in itself and this slow progression in itself a bad prognostic sign? Because it does make sense, doesn't it, that if you have a vigorous immune response and you're acutely unwell, you'll A, be more likely to have a diagnosis made clinically, and B, you're more likely to have positive tests, because what we are testing is the immune response to Borrelia. So if you do have a good immune response, you'll be positive. But I had a delayed and a visibly weak response in the skin. My tests, even after 8 weeks and 14 weeks, were negative. My illness was almost invisible and very easily could have been completely invisible and undiagnosed, especially if I'd not remembered this tick or noticed the very faint EM rash. I also had persistent symptoms. So I began to ask, what if my particular immune response to this particular pathogen is too weak to elicit a positive test and too weak to reliably clear the infection? And these symptoms started to come back with a vengeance when I stopped those antibiotics again, just a few days after that appointment with the infectious diseases team. By then I felt I was on my own. I knew that the diagnosis was post-treatment Lyme disease as far as the NHS was concerned, and I thought long and hard about it. I knew that it could be that the Borrelia had gone and that my symptoms were possibly a post-infectious immune syndrome that the doxycycline had been suppressing, because we do know that doxycycline is anti-inflammatory and it is used a lot for this in dermatology. But I also knew that what I was reading opened up another possibility. And there is nothing like having a disease to make you read about it. And I read voraciously, and I continued to read. I read a lot of the original research literature. I read review articles and patient stories. I read guidelines and books written by doctors in the US and elsewhere in Europe who treat people with Lyme disease. And I also read books by other doctor patients and by patients. And this is what many of our patients also do. When you're faced with uncertainty and you know that what you're experiencing just doesn't fit with what you're being told by conventional wisdom, you look further and you dig deeper. And what I did read made uncomfortable reading, even shocking, and has since stirred me to action to raise awareness of this disease as a result. One of the most helpful articles I read was this review article, and it summarises the biology of Borrelia. Knowing the enemy is of fundamental importance if you're trying to defeat it. And I would encourage anyone interested, and certainly all doctors, to read about Borrelia. It's a truly fascinating pathogen. It has a highly complex genome, 20 plasmids, which is an awful lot, and it's a real shapeshifter. It can change its surface proteins so that an initial antibody response to that protein will become ineffective if it then retracts that and expresses something else. So it really is the master of disguises. It's able to infect diverse species, birds, mice, dogs, and humans, and that alone is really quite a feat. In the birds and small mammals like the mice, it's designed to persist. It sits there alive in the tissues of the animal, and as soon as it receives a signal that the tick is feeding on that animal, it mobilizes to colonize that feeding tick. And that's its modus operandi, to persist and spread via ticks to other organisms. But the ticks might not feed very often, so it has to persist long enough to enable it to spread to the next host. So biologically, that's how it's designed. And that is somewhat concerning. And humans are accidental hosts. We don't know fully what is happening in humans. We know that disease is very diverse, but I guess the the good thing is that we have antibiotics. But it is well documented that although there's no resistance to doxycycline, the organism can create resistant forms in the presence of a threat. There are things called round bodies that Borrelia can create, which are almost resistant hibernating type forms, which will then wake up, if you like, when the antibiotic treatment goes away. And I wondered whether this is what was happening to me. This has certainly been demonstrated in animals and in vitro. And was this the reason why my symptoms were coming back when I stopped the treatment? The other fascinating thing about Borrelia is that there is evidence that it actually targets the immune system directly and disrupts the crosstalk between T cells and B cells. So if it's successful, the B cells, the antibody producing immune cells, will not function properly. And this is a very important concept for us to grasp as doctors. So it might be that in a proportion of patients, Borrelia is successful with its covert infiltration. And because we're relying on the immune response to make a diagnosis, this is a very precarious situation. If the immune system is both blind and disabled by Borrelia, then it won't recognize the organism and it won't fight it, and the test will be negative. And this is a vital question. Are those people who test negative, who have genuine Lyme disease, are they more likely to be more poorly and have persistent symptoms? And this puts us in a really, really difficult position as doctors. Most people do get better from Lyme disease, certainly those with obvious disease. The prognosis is mostly good, even though we do know a proportion of those people do go on to have persistent symptoms. It's easy to see that those with real seropositive Lyme disease get better. But then there are these others who have negative tests, who think they've got Lyme disease, who have non-specific multi-system symptoms and negative tests. It's impossible. I mean, how do we know whether it's Lyme disease or whether it's something else? And certainly not everyone who thinks they've got Lyme disease will be correct, but there will certainly be some. And this has got to be and is a clinical diagnosis based on good, sound history taking and clinical acumen, possibly necessitating a trial of treatment in cases of uncertainty because of these huge conundrums. So we know it's adept at evasion, from the tick bite to the clinician to the laboratory. And Borrelia causes highly variable human disease. Even EM is so variable. Different strains complicate the picture further, so probably cause slightly different disease phenotypes. And the host pathogen interaction is so unique. So people with a tissue type, for example, of HLDR4, who are exposed to the OSP-A or B antigens, have been shown to be more likely to develop an autoimmune arthritis following Lyme. So there's a vast array of symptoms and syndromes that Lyme disease can cause, as we've already discussed. And so there's no typical patient. Complex bacteria that we don't fully understand, and then co-infections can further complicate the picture. So what would you do? It's a question I sort of like to ask. And what do other doctors do when they get Lyme disease? The scenario is that you've come off the antibiotics and yet again the symptoms return, and they seem very, very antibiotic responsive. You know from what you're reading that Borrelia is very complex and that there are reports of treatment failure. And you know that the spreading symptoms do feel very consistent with an active process rather than just a baseline immune dysfunction. You're being told that you've had enough treatment and that you don't need to worry, and that actually you seem very anxious. But you know that your symptoms are not caused by anxiety. You just have real and genuinely valid concerns that you are unable to voice even as a doctor, and feel that the system is letting everyone down, doctors and patients alike. So as a patient, I mean, our patients with Lyme disease do have very real concerns. They read and are aware of some of these other things that are available on the internet, and we're naive to think that they are reading. We would be naive to think that they were reading rubbish. There's a lot of good evidence on the internet, and although guidance is often necessary, they read the same papers and are often very, very informed. So I think as a patient, this is how I feel they look at things potentially, and they know that evidence is lacking. They know of other people who have become very unwell after tick bites. They know that there are limitations to NHS treatment. And they know if they get it later, prognosis is much poorer. And they know that other people have gone abroad for treatment and got better, or reported that they've got better. And you know that there's a lot of controversy. And you might have read some papers and see that there's disagreement amongst even the doctors. And you know that there's not very much research to really tell us what to do. But you inherently do know that just because there's no research trial yet doesn't mean that it's not worth trying. And you just want answers, and you want to just discuss this with a specialist, but there's just not enough time, and your appointments feel pressured, and you know that your doctors think that you're anxious. So from a doctor's perspective, and this might be a GP, it might be an ID consultant, it might be a rheumatologist, it might be any consultant that's seeing a patient with Lyme disease. And I can see this very much from both sides. Patients can come to your appointment with these vast array of symptoms, multi-system symptoms, short clinic appointments, and they're not acutely unwell. And you're in a busy clinic, and they've got a lot of symptoms that you can't explain. Their tests are normal, and they've had full treatment for Lyme disease, as far as the guidance would suggest. And they're visibly anxious. And you wonder if this is exacerbating the symptoms. We know this can happen. We know that stress and anxiety can exacerbate physiological symptoms. That's a genuine concern. And they've had all the treatment you're able to offer them under the guidance, and you do trust the guidelines. Clinics are so busy, and in medicine we do stick to the guidelines. We rely on guidelines. And if there's no precedent for other treatment, there is fear of going outside of that, and there is fear of litigation or GMC referral if you depart from the status quo. So the default is to stick to the guidance which you inherently trust. These patients, as far as you're aware and concerned, have this post-treatment Lyme disease syndrome. There isn't anything else that you can do in terms of active treatment. It's supportive. You talk to them about whether their anxiety is impacting their symptoms, and you might point them to some support services. You expect them to improve with time. You wish them the best. You consider referral to another specialist, perhaps to explore any uncertain causes of their ongoing symptoms. Thus, they get into this linear care sort of model after, seeing specialty after specialty. But you discharge them and you never see them again, potentially. And what actually happens, I think these patients are potentially giving up. They are lost to follow-up, and perceiving that they've hit a brick wall, they often do seek treatment outside the NHS, including abroad. Many report good outcomes, However, long-term outcomes are not being captured. We don't know what really happens, and we don't know what treatments are the most effective because there haven't been the trials. And this has huge financial, practical, safety implications for patients and represents a huge lost learning opportunity and lost feedback for us as doctors. We need to know what's happening to these patients, but they are not coming back. And doctors and their patients are also lacking the benefit potentially of talking to each other. The support and expertise of colleagues in other specialties is very rewarding, and in managing a disease like Lyme disease, where it's so complex, that really would be the best way forward, I think. We do need to talk about this. There are genuine questions, genuine concerns, genuine controversies, and we can't just pretend they're not there. Active, open discussion about the uncertainties amongst clinicians from diverse backgrounds and diverse specialties is vital. We need to pursue the science and embrace the patient stories. We need long-term follow-up of patients and development of clinical expertise here. And it has to be a specialist clinic with multi-specialty and multidisciplinary collaboration. This isn't a disease that can be managed by any single discipline, and research is vitally needed.